Hello everyone, this is Cassie Williams and I'm the PPS coordinator here at Mercy Rehabilitation Hospital in Springfield. This is your FIM Recertification Overview. I hope this presentation is informative and clarifies steps in each FIM category and prepares you for success on your upcoming FIM test. During this presentation, I'm going to go over the program evaluation model, our facility scorecard, and talk about how we all contribute to helping our patients meet their goals. If you have any questions throughout this presentation, please write them down and bring them with you to a live FIM class. You can also contact me at the phone number that's at the bottom of the screen, 417-227-9066, and leave me a voicemail, or send me an email at cwilliams@mrhspringfield.com, or you can also catch me in person. So we're going to start at the very beginning. FIM stands for Functional Independence Measure, and the assessments that occur within the first 3-day period and throughout the patient's stay at rehab take into account both the social and physical context of the person. The FIM also focuses on functional ability, not necessarily the medical complexity of their disease process. The emphasis and goal of rehabilitation programs include improving the functional status of individuals by utilizing a system of interdisciplinary interventions. And outcomes are determined by periodic reassessment of functional changes during the patient's stay. The FIM instrument includes 18 categories, 13 of which are motor and 5 are cognitive. This is a 7-level instrument that allows clinicians to measure the effectiveness of rehabilitation interventions and describe the outcomes in a uniform way with respect to functional status and burden of care. The motor categories can account for between 13 to 91 points of overall FIM, and the cognitive categories can account for between 5 to 35 points of overall FIM. 12 of the 13 motor categories contribute to the motor score index. So that will be all the motor categories except shower transfer that determine the patient's length of stay in rehab. Cognition only contributes with particular diagnoses. The minimum overall FIM score is 18 and the maximum is 126. So the next piece I'm going to talk about is the program evaluation model, which is our facility scorecard. Our PEM score is very similar to a grading scale. It's out of approximately 100 points, which this year it ended up being out of 95.9 points. So you can kind of compare it in that way. This scorecard is how we're compared to all other rehabilitation facilities across the nation, and it really looks at how many of our patients are meeting their goals, how many of them are going to the community, and then how many are going to acute care. So some of you may already know our goals for each year is to get 80% or more discharged to community, 8% or less of our patients discharged to acute care, and 12% or less discharged to SNF. And so I'm going to walk through this just a little bit with you so you can understand just impact of the different areas. Discharge FIM total, when you're looking at that, Medicare dictates that depending on the diagnosis, a patient should be at a certain functional level by the time that they leave rehab, and that is their discharge FIM total. Then when you're looking at FIM change, that's where from admission to discharge, how many points did the patient gain during their stay? And Medicare dictates, once again, based on their diagnosis, how many points they anticipate the patient to gain. Then length of stay efficiency is looking at how many points per day should that particular diagnosis be able to gain while they're in rehab. So our composite score of those 3 things was a 68% last year, and the weight that is multiplied by that percentage is 60. So that is a huge chunk of our overall score. So we got 40.8 points in that section. Then with our percent discharged community, we were a little bit below our goal, which is 80%. We were at 79.7. But according to Medicare, we were a little bit above what they expected us to be based on the type of patients that we brought in. So this is why our facility subscore was a little bit higher, and we ended up getting more than 30 points for that section. So that's where the 31.1 came from. Our percent discharged to acute care last year was 8.7%, which is a little bit above our goal. And although we still gained more than 10 points in this section because, according to the patients we brought in, Medicare anticipated that we were going to have about a 10.1% discharge to acute care. So we ended up with 10.2 points in that area. And our overall PEM score ended up being 82.1, which placed us in the 88th percentile, so it's the top 12% of the nation. And I'll also say we did meet our 12% or less discharge to SNF, because if you add up the discharge to community and also the acute care, that'll leave in 11.6%. So we did meet our discharge to SNF goal. So supporting the burden of care. All disciplines, all environments, 24 hours a day should be FIMing. We need to set the expectation on admission that the patients are to perform at their best across disciplines, including therapy and nursing, as much as possible. And that will be a mindset shift, because as the patients come from the main hospital, they expect nursing to complete a lot of tasks for them. But on the front end, we need to make sure and let the patients know that we are trying to prepare them for their home environment, and we're trying to help them be set up for success when they go home. So documentation of the burden of care by everyone on the team is very important. So when we're looking at burden of care, it's representing the amount of assistance and hours per day that is required to help the patient, once at home, perform basic personal care tasks. And if the burden of care is captured accurately, then the facility will get paid for the provided services. So you really need to look at what is an accurate FIM score on this patient based on how much time are we going to end up spending, how many services are we going to be providing for this patient. So one example that we've used is a spinal cord patient as compared to a knee replacement. That spinal cord injury patient is probably going to need a lot more training on in and out cathing and on a bowel program and on appropriate spinal precautions and transfers and how to use a slide board, possibly depending on where the injury happened, as opposed to a knee replacement patient who may just need a little bit of help with their weight bearing precautions and some education on knee precautions and all that kind of thing. So we are spending more time and resources with the spinal cord patient as compared to the orthopedic patient. So that's just one way to look at it, for getting reimbursed for the care that we're providing, not necessarily that the facility will get paid more because we're FIMing them lower. And if we're FIMing accurately, we're giving the patient the amount of time that they truly need at rehab so that they can be successful as soon as they go home. So where can information be obtained on burden of care? The gold standard is going to be direct observation, especially during the admission period. We want to establish a baseline for the patient. So as much as possible, we want to observe activities occurring, and we don't want that to be skewed by what the patient or the family thinks that the patient should be able to do as compared to what they're actually doing. Credible reports of performance can be taken from the patient, other staff members, families, or friends. Just be aware that if you're going to take a report, think about if they're cognitively intact to be providing this information to you. And like I said before, just be aware during the admission period that we're truly capturing their burden of care and setting a baseline for them so we have something to go off of when we're nearing discharge. Couple important reminders when you're scoring: consider, did you give the patient adequate time to complete the task, or was it for your convenience and did you rush the patient? So just make sure you're giving the patient an opportunity. Did you bring 2 people in there to get it done quicker, which I understand from an efficiency standpoint, but look at, did you give the patient opportunity? Could they have put their shirt on by themselves if you would have let them and given them appropriate amount of time? So that would be a non-FIMable occurrence if you brought 2 people in there just to get it done quicker. So just be aware of those things when you're scoring. A couple more important reminders: plan your care. Like I said, allow adequate time for the patient to perform the task versus performing the task for the patient. Completing the task for the patient should be a rare occurrence in rehab. We really want to give our patients an opportunity to participate in the rehabilitation process. With that, I'm aware there's a lot of things to get done. Just know that our goal is to allow the patients to participate so they can be successful once they go home. So this next section is going to focus on the motor categories and the scoring of those activities. So we'll start with an independent FIM rating. That would be you and I performing these things without an assisted device. Modified independent would mean they would need an assisted device or they may need more than a reasonable amount of time to complete the task. Supervision and setup means the patient needs supplies, devices, or supervision and cues for safety to perform the activity. Minimal assist, the patient's completing at least 75% of the task or requires steadying assistance from the helper. Moderate assistance means that the patient's participating in 50 to 74% of the activity. Maximal assist means the patient is participating in about 25 to 49% of the activity, and then a total assist means the patient's participating in less than 25% of the activity, or 2 helpers are involved to safely complete the activity. One other area I'm going to look at is the activity did not occur, which would be a 0. The expectation is minimal use of this selection. You must document the reason the activity didn't occur. So in the comment box in UDS that's right underneath where you would normally select your options for scoring, you can place a reason why. Use this option only when the patient did not perform the activity and the helper did not perform the activity for the patient during the entire assessment time frame. So if a patient was transferred from stretcher to bed with 2 helpers as a bedded chair transfer, that's not FIMable. So, and that patient never got out of bed for the entire 3-day period, that would be when you would put a 0 for that. Most of our patients, that will not be the case, because unless they were on hold, medical hold or something like that, that would not be the case. But just be aware that would be a situation. I'm going to have a couple other examples coming up. So just like I said, if the patient didn't transfer to or from the bed or chair, and the helper did not use a mechanical lift to perform the activity with the patient during the entire shift. Documenting that the activity did not occur would be indicating that the patient never got out of bed. So just be aware of that when you're doing documentation in FIM. Try as much as you can to use the comment boxes instead of documenting activity didn't occur, because it looks like we're not providing care to our patients when we are. So just be aware when you are selecting that. Some justifiable reasons for activity did not occur: if the activity is unsafe, so stairs for a person with lower extremity paralysis, a current medical status may be prohibiting the patient, walking for a patient who's unable to bear weight on lower extremities would be acceptable. If the patient refuses to dress in clothing other than a hospital gown or refuses to be dressed by a helper, that would be another reason. That would be okay to put activity did not occur. But like I said, we want to give the patients opportunity to complete these tasks, especially during the admission period and throughout their stay and then at discharge. So to ensure we're capturing the burden of care, avoid using the selection of activity didn't occur. When an activity is performed at the end of the shift, make sure to chart that activity, especially showers. If you perform a shower with a patient, it's expected that it's put into UDS, looking at not only the shower, but the shower transfer, the patient's ability to dress themselves, and also looking at grooming within that same time frame if you're in there doing all of those things, just to make sure and grab those FIM scores so that we can have an up-to-date overall FIM for that patient if we're getting ready for team conference or if the patient's getting close to discharge. So the next piece is going to be specific for each category. So we're going to start with eating. So there are 5 things that are really included in eating: picking up a utensil, scooping food, bringing the hand to the mouth, chewing and swallowing, and drinking from a cup or glass. So one thing I want you guys to remember is eating must be scored as a whole meal. Don't FIM snacks or med pass in this category. We are just wanting to capture endurance with the task of eating. Another thing that's included in this would be if the patient's on a tube feeding. Most of our patients are having tube feedings administered by the nurse, so they would be a 1 in the eating category. If the patient is able to complete a tube feeding with setup and all the things are brought to them and they're able to do it to gravity or to program the pump so that they can complete the tube feeding, then they could be a 5. And then if the patient is able to gather their own supplies and complete this independently, then they would be a 6, which is very few of our patients, but just be aware of that. If the patient is on continuous IV fluids for hydration, then that would drop the patient down to a 1 as well. Also, if they are having water flushes through their PEG tube for hydration, that would also drop them to a 1. Dentures are considered as an assisted device in this category, so be aware of that. And if the patient is on modified textures or thickened liquids, that would also be a modified diet. So both using dentures and also the modified diet would drop the patient to a 6 for eating. Then if they're needing containers opened, things like that, and setup of all of their equipment and stuff, then they would be a 5. Same thing with putting in their dentures. If they need someone to put their dentures in, they would be a 5 as well. So we're going to move on to grooming. Grooming includes oral care, combing or brushing the hair, washing, rinsing, and drying the face, washing, rinsing, and drying the hands, and then optional is shaving the face or applying makeup. The reason that "and" is bolded and underlined is that if the patient's not able to complete all 3 of those things, washing, rinsing, and drying, then they don't get credit for that task. So just be aware of that when you're scoring. Grooming can be performed in sitting or standing. Ideally, if the patient stood at home, we're going to want them to stand while they're here because we want to set them up for success when they go home. And if the helper has to bring the grooming supplies to the sink from the bedside table, this is setup assistance, so would be counted as a 5. And also, if the patient's standing and they require standing assistance, then they will be dropped to a 4, minimal assistance for this task. And when you're documenting, we want to encourage at least 2 of these tasks to be completed for a FIMable occurrence in order that we can really look at endurance similar to with eating. We need to look at the patient's ability to complete at least 2 tasks. If you only have them complete 1 task, it can be falsely inflating their score if you just have them wash, rinse, and dry their hands and then move on. So we just want to truly capture the burden of care, and that's why we're asking that at least 2 of these tasks are scored for a FIMable occurrence. Bathing includes washing, rinsing, and drying the body. So the following 10 parts: the chest, left arm, right arm, abdomen, perineal area, buttocks, left upper leg, right upper leg, left lower leg, including foot, and right lower leg, including foot, are all the pieces that are included. There are 3 tasks per body part: washing, rinsing, and drying, very similar to grooming. So be aware of that. If they're not able to dry that part or they're not able to rinse the part, then they don't get credit for that part. And remember not to include the back, neck, face, hands, or hair. So a few considerations for bathing. Bathing can be performed anywhere, can be performed in the bed, on the edge of the bed, in the shower. The location doesn't affect the FIM rating. It's based on the number of parts that are washed, rinsed, and dried. Assistance in and out of the tub or shower is not included in a FIM rating for bathing. That's a separate category in tub shower transfer. Ideally, all the body parts will be bathed, but not all body parts have to be bathed to rate bathing. Only rate the parts that you observe completed during that time frame. On some of the questions in the FIM test, it may say that the patient only completed 3 items and the helper did not complete any further items. That's why you would just go out of 3 parts. If the patient is an amputee, then the body part does not exist, therefore it can't be counted. So if the patient was a left below the knee amputation, you would not count the left lower leg and foot since it doesn't exist, so it would just be out of 9 body parts that you would rate the patient. Next, we're going to move on to upper body dressing. This includes dressing and undressing, as well as applying or removing a prosthesis or an orthosis if that's applicable for the patient. So in this particular situation, we're going to look at upper body dressing with a button-up shirt. So thread the right sleeve, pull across the back, thread the left sleeve, and button up the shirt would be your 4 steps that would be included in this area. If the patient has a TLSO brace, you don't count steps on the brace. Just if a helper is needed to apply that brace, then they wouldn't be higher than a 5 because they need setup of their supplies to complete the task. If you're looking at a t-shirt, you would thread the right arm, thread the left arm, over the head, over the trunk. So once again, 4 steps. And also, the patient's FIM score can't be higher than a 5 unless the patient gathers his or her own supplies for that task. So just keep that in mind when you're scoring. So we'll move on to lower body. And with this particular one, we're going to talk about pants. So there are 3 steps included in this category: threading the left leg, threading the right leg, and pulling up the pants. If the helper assists with compression socks, tubing grips, an AFO, the patient can't be higher than a 5, just like with a TLSO brace. And just be aware if the patient is using a long-handled shoehorn or a reacher to complete lower body dressing, they would be dropped down to a 6 if they're using it independently. And when you're looking at socks, there's an additional 1 step for each sock, and then 1 step for each slip-on shoe. Shoes with a tie or buckle are 2 steps each. So just be aware of those things when you're scoring lower body dressing. If the patient is using the walker to retrieve the clothes, that is not FIMable because that's a transfer score. But if the patient's using the walker similar to a grab bar to steady themselves while they're pulling up their pants, and they don't need any additional assist and they're safe doing that, they would be a 6 because they're using it as a grab bar for an assistive device. So some considerations on upper body and lower body dressing. The clothing must be appropriate to be worn in public. Upper and lower body dressing includes a patient obtaining the clothes from customary places, so drawers or a closet. Putting on and taking off scrubs may be appropriate for purposes of assessment, but gold standard is going to be using the clothing that the patient will wear in the discharge setting. So be aware of that. In UDS, you'll be prompted to rate assistance for each step of each article of clothing. Depends are assistive devices in bowel and bladder, not underwear, so don't score this. In lower body dressing, don't score tubing grips as socks. They're orthotics, so they don't have additional steps in lower body dressing. If a helper's having to assist, they won't be higher than a 5, so be aware of that. Another thing that comes up on the test is incidental help. So this would be assistance with buttons, zippers, or snaps only. Be really careful because incidental help means help with 1 zipper or 1 set of snaps or buttons. If help's needed on every article of clothing, it's not considered incidental help. The only reason I put that on there is for the test because that trips some people up. Most of the time when the question's asking about incidental help, the patient will be a minimal assist because they're able to do just about everything else on their own. So just be aware of that. We're going to move on to toileting. So the steps included in toileting: managing clothes before voiding or having a bowel movement, perineal hygiene, and managing clothes after voiding or having a bowel movement. So there's 3 steps. We really want to encourage our patients to get up to the toilet or bedside commode to FIM this. A bedpan may be used on the FIM test. This should be scored in practice only as a rarity. The majority of our patients do get up. Very few of them use the bedpan, but it can be a little bit confusing because you're looking at management of clothes, perineal hygiene, and then once again management after they've had a bowel movement or have voided. So getting patients up to the bathroom will provide the most accurate burden of care. So just keep that in the back of your mind. So there's 3 steps in toileting. And next we're going to go on to bladder management. Bladder management includes the intentional control of the urinary bladder, equipment, or medication used for control. So we're looking both at sphincter control and frequency of accidents. If the patient has medications that they use to maintain their continence, they would be a level 6, but if prior to admission the patient had 2 accidents right before they came, then the patient will be rated as a 4 for frequency of accidents. So you would take the lower of those 2 scores, and the program will do that for you. But something that's really important when you're completing your admission assessment is going into the rehabilitation nursing admission assessment and doing a 4-day look back on the acute stay. If the patient's from a Mercy facility and we can use Epic, we want to do that 4-day look back. However, if the patient's from an outside facility, it is acceptable to talk to the family or the patient if they're cognitively intact and ask them how many times that they had an accident in the other facility. And I want to clarify the difference between incontinence and accident. An incontinence is contained within a brief. An accident soils the linen or clothing, and they have to be changed. So just be aware of that difference when you're scoring in your daily shift assessment. So we're going to move on to bladder management and assistive devices. Medications would be one thing that would drop the patient to a level 6. Examples of medications would be uricoline and ditropan. Those are both controlling the sphincter, and those are the medications included. Lasix does not count in this category, so be aware of that. Lasix is working on the kidneys. A diaper or brief would be included in this category. Intermittent catheters, indwelling catheters, urostomies, bedpans, bedside commode, and also urinal. If the patient does not void, has renal failure, and is on hemodialysis or peritoneal dialysis, they should be rated as a level 7. Don't grade them down for hemodialysis as it's not dealing with sphincter control, rather with the kidney. So be aware of that. Bowel management includes both sphincter control and frequency of accidents, just like bladder management does. Also with this, when the patients are admitting, please make sure to complete the rehabilitation nursing admission assessment, where it will prompt you to look at the 4-day look back on the acute stay. So bowel management, assisted devices, medications, including laxatives, stool softeners, enemas, suppositories, those kind of things will all drop the patient to a level 6. As soon as you get into suppositories, you have to look at, did you just insert the suppository, which would be a level 4, as opposed to doing digital stimulation as well, which would drop the patient down to a 1. So just be aware of those things. Colostomies and ileostomies are also included as assisted devices in this category. If the patient's needing assistance cutting out circles and portions of the appliance, to place it around the stoma, to replace a new bag, to empty the colostomy or ileostomy bag. Those things would all come into setup and how much assistance and those kind of things, so keep that in mind when you're scoring that area. Bedpans and bedside commodes also count in this category. Prunes, herbal teas, and natural laxatives do not count as medications, so keep that in mind as well. So we're going to move on to the bed chair, wheelchair transfer. The great thing about the next three categories is they are pretty similar in the drop downs because you're trying to get from one place to another, so just be aware of that. It'll make each of these areas a little bit easier to score. Bed chair wheelchair transfers include all aspects of transferring from a bed to a chair and back, or from a bed to a wheelchair and back, or coming from a standing position if walking is a typical mode of locomotion. And this all starts in the supine position, so be aware of that. Supine to sitting, moving the legs out of bed, sitting to standing, pivoting or transferring to the chair, standing to sitting in the chair. So just be aware of those things when you're scoring. It's the whole process, and you're looking at the heaviest burden of care, whether it was from getting from the bed to the chair or from the chair back. Those are some questions that will try to trip you up in the test. It may say the patient required minimal assist to get out of bed, but then required maximal assist, so you would look at the lower FIM score for the appropriate answer for those questions. So for a toilet transfer with a wheelchair, you would go from the wheelchair to standing, which could be lifting assistance if that's required. Transfer to the toilet, could be with a slide board or a stand pivot. Sitting on the toilet, and that will be the lowering piece. Then standing from the toilet, transfer from the toilet, and then sitting in the wheelchair. So those are the pieces included in the toilet transfer. Then when you're looking from a walker standpoint, going from the walker to the toilet, sitting on the toilet, and then once again standing from the toilet. Some considerations when looking at the toilet transfer would be that toileting and the toilet transfer are two separate categories. Toileting is the management of clothes before voiding or having a bowel movement, perineal hygiene, and then managing clothing after voiding or having a bowel movement. And toilet transfer is only looking at how the patient gets from the chair or walker to the toilet or commode. The tub and shower transfer includes getting into and out of a tub or shower. The patient performs this activity safely. So the patient would go from the wheelchair to standing, transfer to the shower bench or chair, sitting on the shower bench, standing from the shower bench afterward, transfer from the shower bench, and then sitting in a wheelchair. When you're looking at this from a walker standpoint, the patient would walk into the shower with the walker and sit on the shower bench or stand, then stand from the shower bench or walk out of the shower after they're finished. So some considerations: this transfer cannot be simulated. The patient must be wet and fully undressed to score this area. The reason why is because of the safety aspect of the floor being wet, and they will encounter that when they get home, so just making sure that they know how to manage that situation. Locomotion includes walking on a level surface once a patient is in the standing position, or using a wheelchair on a level surface once a patient is in the seated position. So what you're wanting to look at on these questions on the FIM test is the distance. There's three separate categories: less than 50 feet, 50 to 149 feet, and then 150 feet or more. And that'll determine what scores are available for that patient. So I'm going to show you one of the charts, and you'll be able to use this for your FIM test. If they go less than 50 feet, no matter how many helpers they have, they're going to be a total. And then when you're looking at 50 to 149 feet, they could be anywhere from a total assistance to household ambulation, which would be the patient is able to walk with or without a walker between 50 to 149 feet, or the patient's able to propel their wheelchair 50 to 149 feet. And as you can see by this next chart, there are many more options for FIM scores between a 1 to a 7 based on the patient's performance, how many helpers are involved, and if an assistive device is needed. So I would strongly encourage you to use the chart that I'm going to give you for your FIM test. And next I'm going to talk about a few considerations for this section. When you're looking at the questions, look at the primary mode of locomotion, walk or wheelchair, to determine which score that you are going to utilize for the question. Use the chart that I'm going to give you for the test. And whenever you are documenting FIMs, make sure not to score this category. Only PT is to document this because they're assessing gait. They're looking at a lot more pieces. They're giving the patient opportunity to walk as far as they can go or to propel their wheelchair as far as they can go, where a lot of times we're just taking them back and forth to the bathroom from a nursing perspective. So just be aware of that. Then when you're looking at stairs, this includes going up and down 12 to 14 stairs or one flight indoors in a safe manner. So when rating this item, you've got to focus on the number of steps, the level of assistance, and the use of devices. So on this next slide, it's a very similar chart to the one you just saw with locomotion of walk and wheelchair. So fewer than 4 stairs with at least one helper, the patient's going to be a total assist. Then if the patient's able to do 4 to 11 stairs, they can be anywhere from a level 1 to a level 5. And then if the patient is able to go 12 to 14 stairs, which would be a full flight, then they can be anywhere from a level 1 to a level 7. Some considerations: make sure and use the chart for the test, and don't FIM this category. Only PT is to score this category. So you made it to cognition, so you're almost finished. So we're going to finish out these last 5 categories. Cognitive categories and scoring of those activities is going to be listed below. We're going to start with a level 7, which would include complex, abstract directions, ideas, problems, and the patient being able to self-correct. Then we would move on to modified independent, which would be the same as the independent category, except it would require more than a reasonable amount of time. Then moving on to supervision and setup, the patient requires prompting and cueing no more than 10% of the time. Then minimal prompting and direction. The patient's able to deal with those cognitive situations 75 to 90% of the time. Moderate prompting, the patient's able to perform those activities 50 to 74% of the time. Maximal prompting, the patient's able to perform those activities 25 to 49% of the time. And then total prompting means they're not able to do much of anything on their own. Less than 25% of the time they're able to perform those activities. Cognition is scored on a 24-hour time frame, so be aware of that. If a question on the test refers to the patient being confused a certain number of hours, you would look at the total number of hours that they are not confused and that they're participating, depending on which kind of category you're looking at. So you're going to be looking at the full 24-hour period and how many hours are they appropriate in whatever category they're dealing with. So comprehension includes understanding of either auditory or visual communication. It's really important to determine whether the patient has better comprehension from an auditory standpoint or a visual means, and if they're understanding basic or complex information. For instance, complex information includes humor, medical issues, work history, religion, current events, those kind of things. Then basic information would include directions, questions related to the patient's need for nutrition, fluids, elimination, hygiene, and sleep. Some assisted devices that would be included in this category would be hearing aids and glasses. So just be aware of that. Once again, you need to rate this item across all environments, the patient care unit, therapy gym, over the entire 24-hour period, and rate this item based on the patient's usual language, and that may not be English. So if the patient needs an interpreter, the interpreter is not considered as an assistive device. So just be aware of that. If the patient's needing us to put in the hearing aids or put on the glasses, the patient would drop to a supervision setup. Then looking at expression, this includes clear, vocal, or non-vocal expression of language. So it's important to determine whether the patient uses primary vocal or non-vocal means of expression. And once again, this item should be reflective of a 24-hour period. So this category has to do with the patient's ability to express complex ideas and or basic needs. Assisted devices included in this category would be the passing mirror valve or communication board. So be aware of that. Once again, if the helper needs to put on the passing mirror valve for the patient, then they would be no higher than a 5 for this area. This is the same thing with the interpreter. They're not graded down for having an interpreter. They would not be a level 6. They could still be a level 7 if they just needed the interpreter and they were able to express themselves appropriately. So moving on to social interaction. This includes skills related to getting along with others and participating with them in therapeutic and social situations. It represents how the patient deals with his or her own needs together with the needs of others. So a couple questions you may want to ask yourself when scoring this category. Is the patient cooperating? Is the patient participating? And is the patient exhibiting any inappropriate behaviors? So some assistive devices in this category would be medications, whether that be anti-anxiety medication or antidepressants, redirection and encouragement to participate. So be aware of that. If the patient uses physical or chemical restraints to prevent socially inappropriate behavior, then the patient would be rated either a level 2 or lower, just depending on the percentage of time that the patient is interacting appropriately. Some inappropriate behavior would be the use of foul language, temper tantrums or outbursts, inappropriate laughing or crying, physical attacks, a very withdrawn or non-interactive behavior. So be aware of those things, and once again, the questions on the test will talk about the patient acting out maybe 3 hours of the day, so you'd look at 21 out of 24 hours. So the patient would be interacting appropriately approximately 88% of the time, which would make them a minimal assist. So think about that when you're taking the test. Then when you're looking at problem solving, this includes skills related to solving problems of daily living and involves making reasonable, safe, and timely decisions regarding financial, social, and personal affairs, as well as initiating, sequencing, and self-correcting tasks and activities to solve problems. So some things to consider: recognizing that a problem is present would be one of the first things to assess the patient for. assess and see if the patient is making appropriate decisions, if the patient is initiating steps and readjusting to changing circumstances, if they're able to carry out a sequence of steps, and then able to evaluate solutions. So some examples of complex problem solving would be using a checkbook accurately, and then some basic things would be following commands, using the call light for staff to help you before you get up, mobility and transfer. So being able to sequence that appropriately would be another problem solving task. So memory, this includes skills related to recognizing and remembering during the performance of daily activities in an institutional or community setting. In this context, memory is looking at the ability to store and retrieve information, particularly verbal and visual information. So the three key components that are focused on in this category: remembering people frequently encountered, remembering daily routines, and executing requests without reminders. So once again, cognitive areas should go across the 24-hour time period, and there should be input from all the team members. Don't rely solely on evaluations from a specific discipline. Just be paying attention to how the patient's interacting across all of their stay in the hospital so that you're getting the most accurate scores on the patient. So you've made it to the end. We're just going to quickly summarize what we talked through. Read the drop downs each time you use UDS. Make sure to read the selections from the bottom up in order not to miss selections, and we'll talk a little bit about this in the live class. The burden of care impacts the length of stay for the patient, and then careful documentation will support the burden of care and the services provided to each patient on an individualized basis. So give me a call, email me, catch me in person, or I'll see you at FIM class with any questions that you've got. I really appreciate your time and hope you have a great day.